This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, it's Jeff Ratliff with the Neurology Podcast. I'm here with Vikas Kotagal, a neurologist at the University of Michigan. We invited Vikas to join us to discuss a paper he published with his team in neurology clinical practice titled Neighborhood Social Determinants of Health in Patients Seen in Neurology Movement Disorders Clinics. The article was published online on March 16, 2023. And in this study, Vikas and colleagues retrospectively examined the patients coming through their movement disorder center and looked at specific demographic and other census data to evaluate for associations between patients' diseases and social determinants of health. Vikas, welcome. Thanks for joining us.
Thanks for having me, Jeff.
So Vikas, let's just start with the primary findings of the study. And you were looking more specifically at patients coming to your center, examining for associations between their diagnoses and data about the neighborhood in which they live, if I have the findings correct. Can you go ahead and summarize what were the main findings from that analysis and from this project?
We looked at individual patients coming to our movement disorders neurology clinical practice here at the University of Michigan in the calendar year of 2021. And we looked not at patient level factors, but rather at the neighborhood factors associated with the census tracts from which the patients came from, to try to understand factors that describe the neighborhoods that patients are coming to us from amongst our cohort. And it included about 2,400 individual patients. We found that lower socioeconomic status related factors, including a greater proportion of people earning less than $15,000 a year, a greater fraction of people receiving public assistance, and a higher likelihood of people in the neighborhood having less than a high school diploma. These lower socioeconomic status factors were seen more commonly in individual neighborhoods of patients who follow with us for Huntington's disease, for ataxias, or for functional movement disorders, relative to those who follow with us for Parkinson's disease. We also noticed that people with PD or with atypical Parkinsonian conditions like PSP, CBS, or MSA tended to be older than other movement disorders patients and were more likely to be married compared to other movement disorders patients. So those are sort of the two central findings.
Okay, so I want to dive a little deeper into some of those diagnoses you examined and some of the social determinants of health that are at play here. The most common movement disorder that we see in our practice is Parkinson's disease, as well as other patients with other Parkinsonian disorders. And you mentioned in the discussion and touched on a little bit just now that patients with PD and the atypical Parkinsonian disorders tend to come from more affluent neighborhoods. Can you teach us a little bit about maybe some of the reasons that you observed that finding?
Yeah, it's a little bit of conjecture, but I think that these are observations that many of us in movement disorders practice have noticed before. One is just that the age of onset of PD, neurodegenerative Parkinsonian conditions, tends to be in adults who are a little bit older than those who are developing nascent tic disorders, for example, or even monogenetic disorders like Huntington's disease or SCA3. So you're looking at a subgroup of individuals who are a little bit older. We found that they were also slightly more likely to be married. And I think that those two demographic factors amongst patients, at least in my guess, associate with slightly more affluent neighborhoods from which those patients come, with the idea being that if you're more likely to be married, you're more likely to come from a dual income household, and that may associate with a greater degree of affluence. Similarly, if the onset of your movement disorder comes later in life, you may have acquired more income and wealth prior to the onset of that disorder. And so your relative affluence may be higher than those who have the onset of their neurologic condition earlier in life.
And so if we switch over to one of those monogenic disorders that you alluded to, was specifically talking about Huntington's disease, you mentioned that patients with HD do tend to come from more disadvantaged neighborhoods by those metrics that you described. And you describe in the discussion of this paper that perhaps even some of the premotor manifestations in HD and Huntington mutation carriers might contribute to difficulties in accessing resources or even doing well in a workplace environment. And so refresh us on a little bit of what you found for patients with Huntington's disease and maybe discuss a little bit about why some of those findings might be coming to light.
Similar to what I had mentioned previously, I think that many of us who practice in movement disorder specific practices have suspected or noticed these trends in our own patient populations before. And so in many ways, this study is just sort of articulating what I think many of us noticed. And there is a really interesting literature on HD epidemiology as it relates to premotor HD. Premotor HD is often defined by having 36 CAG repeats in your Huntington gene or more, but not yet having the onset of motor symptoms of HD. And that's different than individuals who have an indeterminate repeat length that may vary from 27 to 35. So two slightly different constructs I just want to define there. But there's a literature on premotor HD that suggests that people with premotor HD are more likely to have difficulty finding and sustaining employment and with performance at work, and are also more likely to have sort of non-motor features of HD, including neuropsychiatric features. So it's certainly possible that the presence and persistence of those clinical features may be influencing earning potential and overall affluence amongst HD patients. And I think that for many of us who see HD patients, this is kind of an expected finding.
I think it's important to recognize that in a study like this, looking retrospectively over the patients who came to your center over 2021, determining any sort of causation is very difficult. We're looking at these associations, but thinking about how they fit into a broader context of what we know about the movement disorders that we're describing here. And I think that's coming into play as we talk about patients with functional movement disorders. And again, you described that patients with functional neurologic or functional movement disorders were coming from neighborhoods with lower income or lower average education levels. And so given those caveats about a retrospective study and the difficulties or impossibilities in determining causation, I'm hoping you can describe some of the reaction to these findings. What are the factors that might be going on with respect to social determinants of health for patients we see with FND?
So FND refers to functional neurologic disorders, as you said, and sometimes people use the term FMD, M as in Mary, for functional movement disorders, but I'm going to use them kind of synonymously. And I think an analogous term is PNES, so psychogenic non-epileptic seizures, that characterizes functional disorders seen in epilepsy-specific practices at referral centers such as ours. And there's an interesting literature that exists that shows that PNES, individuals who have PNES whose non-epileptic seizures resolve over time, are more likely to be those who are affluent, who have a college education, who have employment, and those who don't have a resolution of their symptoms are less likely to have current employment status and higher education. So we know that there are, on a big picture level, these broader demographic factors that appear to influence the natural history of functional neurologic conditions. So not only was it interesting to find that in our cohort that FND is associated with relatively lower markers of socioeconomic status, it also raises the question about whether there is some modifiable risk factor that might exist here that could alter the natural history of FNDs amongst patients that we're seeing in our clinic that may not be a risk factor in the sense of a drug treatment target, but is more of a social determinant of health sort of risk factor that could be addressed either through policy or through behavioral interventions or medical education.
That's important as we start to think about modifiable risk factors and sort of pivoting to the portion in this paper where you describe these findings as really begging for a future longitudinal prospective study. And you found a lot of these associations between movement disorders and the neighborhoods that the patients with those disorders are coming from, things like income and education that we've already been talking about. And so what could a future longitudinal study help us learn about some of these associations that you described in this paper?
I want to talk a little bit more about some of the limitations of our approach, because you're absolutely right. It is a retrospective study, and we did not gather information from patients directly. Instead, we used an existing data set called the U.S. National Neighborhood Data Archive, or NANDA, which is linked to census tracts. And census tracts you can think of them kind of like zip codes, but they're smaller. They're anywhere from 1,000 to 12,000 people, and on average around 4,000 people. So they describe discrete areas that are closer to neighborhoods than they are zip codes. But that's not the same thing as actually surveying or asking a patient about social determinants of health relevant to their own life. So one, we have this retrospective design. Two, we're using this large representative NANDA database, but we're not asking people directly. Another important thing is that the data and the inferences that can be drawn from our data are really heavily linked to the context that we're drawing these data from. I mean, we are a university-based movement disorders clinic nested within a suburban town in the Midwest, and inferences drawn from our center may or may not be relevant to movement disorders centers elsewhere throughout the world. I think one relative advantage of our approach is that we were able to capture a large group of people who were given specific diagnoses by movement disorders clinicians, and that in and of itself overcomes a certain hurdle that's often faced by movement disorders epidemiology, which is case ascertainment, particularly for conditions like functional neurologic disorders or even things like Parkinson's disease or tic disorders. So there are upsides of our approach, but there are also downsides. There are many future studies that could come out of this. I think that our work really just barely skims the surface of what role social determinants of health have on patients with movement disorders. And I think it would be very interesting to delve into a greater depth in specific conditions like functional disorders, like spinocerebellar ataxias, or even like Parkinson's disease, not just to try to understand associations, but try to understand whether there are associations that are modifiable and that might drive the natural history and outcomes of patients with these conditions, thereby opening up new treatment possibilities that we don't yet have.
Now, knowing what you've learned from doing this study, when you see a patient in the office with Parkinson's disease, or when you're seeing a patient with Huntington's disease or ataxia or functional movement disorders, has the knowledge from this project changed how you're managing or assessing or talking to patients in the office? And could you give us an example of how that has changed your clinical practice?
I do wish I had a very concise way of summing up how conducting the study and seeing these data have changed my clinical practice. I don't think I have something that I can tie up nicely that way. If anything, what seeing this data has done for me, it hasn't so much changed the types of questions I ask patients. I hope it will, but it hasn't yet done that. But I think what it's done is it's made me a little bit more curious about things that I probably ignored previously. Just things like, who's cooking at home? If you're getting in the car, who's putting your walker into the car? If you have a power outage, how do you deal with that? Those aren't really questions that I tend to ask most of my patients, but I'm increasingly curious about the answers to those questions. Often, especially in Parkinson's disease, we do spend a lot of time talking about exercise, talking about the natural history of the condition, talking about diet. But I don't know that we spend a ton of time talking about the myriad of other just normal social determinants of health that matter and that influence people's lives and probably influence the type of symptoms they experience and the severity of the burden of symptoms they experience. So if anything, I think I'm just more curious about those. And since seeing these data, and I have a broader set of family of questions to ask people these days than I did before.
Yeah, I think that makes total sense. And as we are increasingly aware of these elements of social determinants of health that have the potential to have an impact on our patients with various movement disorders, then you're right, that begets questions that we ask about the environment. Is it marital status? Is it having someone at home who can help them, put the walker in the car and things like that? So I think the awareness is hopefully going to lead to sort of questions for us to just better understand the interaction that our patients have with the environment that they live in and how that can affect their ability to access care or optimize their care or just, live as well of a life as they can. Vikas, thank you. I wanted to thank you for joining us. And for our listeners, I've been speaking with Vikas Kotagal from the University of Michigan about his paper that was published in Neurology Clinical Practice titled Neighborhood Social Determinants of Health in Patients Seen in Neurology Movement Disorders Clinics. Vikas, thanks again for joining us.
Thanks so much for having me, Jeff.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.